Welcome, everybody. Good afternoon or morning, wherever you may be. Welcome to the October 2022 quarterly Arkansas APCD Data Users Group. This is our 13th session. For those of you who are new, I see lots of familiar names, but I'm going to assume that perhaps there's someone new that I didn't see. The Arkansas APCD is, I'm sorry, there's somebody. The Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, which is called ACHI and is administered by the Arkansas Center for Health Improvement, or ACHI. That's where I am. The Arkansas APCD is comprised of private and public carrier, medical, pharmacy, and dental claims, as well as enrollment and provider data. The HTI, the APCD is part of this, also includes additional key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics data, birth certificates, death certificates, hospital discharge and emergency department data for individuals who are self-pay or who are uninsured, the cancer registry data, some older medical marijuana card holder data, which is still very valuable. And we also have some Arkansas Workers' Compensation Commission data. This is not the data from employers, but from the state agency itself. We hope that you find today's session very helpful. And some housekeeping rules before we move forward. Feel free to type any question in the chat. We'll address them as we can. At the end of today's session, we will provide a link to our service desk application where you can enter any question or topic you're interested in discussing, whether it's related to this data users group or not. The Arkansas APCD can be a complicated beast. You can also request time with our team to address specific questions you may have about how to use or interpret the data. The link to this deck and recording will be provided in the follow-up email that you will receive at the conclusion of this session. And finally, the next data users group will be January 25th, 2003. And that said, I need to make certain that I'm recording. Stand by. And I am.
Echo Orden took care of that.
Oh, thank you. I have a good team. All right, I'm going to go off camera and then we'll go to the next slide. Okay. All right, our agenda for the day. We have, well, let me say first, our agendas are developed with user input. We get the most useful information from our data users. If you have ideas for topics, please let us know either by entering in the ideas in the chat or emailing us, and maybe we'll include them in future presentations. We want to make everything we discuss very interesting and have a variety. Today's agenda, we have a featured presentation, Family Map Inventory, Adverse Childhood Experiences in Healthcare Utilization and Outcomes, Arkansas Opioid and Naloxone Prescribing Trends, data users questions from other APCDs, the latest APCD release information and data tips. We have new data, so this will be very timely, and then any questions or discussions. I will say, depending upon time, sometimes there's a lot of information to share. I may skip over the data user questions from other APCDs. Those slides will be in this deck when you get the link after. So it will be there. Hopefully we'll have time to go over them, but we'll see. All right, the next slide. Our presenters today, I'm Kenley Money, the Director of Information Systems Architecture and APCD Director at ACHI, the Arkansas Center for Health Improvement. Our guest is Dr. Dong Zhang, University of Arkansas Medical Sciences Department of Family and Preventive Medicine, and Mike Motley, Director of Analytics at ACHI. All right. Without any further ado, I'm going to turn this over to Dr. Zhang to talk about his project. And Dr. Zhang, why don't you introduce yourself? Here's your bio.
All right, thank you, Kelly. Thank you for ACHI for this opportunity. My name is Don. I'm an instructor at UAMS College of Medicine, Research and Evaluation Division. I have this is my kind of bio. I have a master in stat, public administration, doctorate in Human Development and Family Studies from Iowa State. So I joined UAMS in 2020. Yeah, so it's really an honor and pleasure to be the speaker today. And I think we'll just get started. All right. So a little bit of background information. So research study have shown that there is a gap in the effective translation of prospective adverse early childhood experiences or ACEs screening to clinical settings. With that in mind, our long-term goal of the study is to develop generalizable and feasible strategies for healthcare providers to screen for ACEs that leads to insufficient preventive medical care and chronic conditions. To achieve that goal, through this aim in the current study is to determine the association of the Family Map ACEs score at toddlerhood, which is between age 3 and 4, and healthcare utilization and health outcome within 1 year of the date of the interview. And this study is supported by the funding of College of Medicine Barton Pilot Award. Really appreciate their support. Next slide, please. So ACEs, what is ACEs exactly? In general speaking, it refers to potential traumatic events that occur during childhood. ACEs has significant impact on person's physical, emotional, and mental health throughout their lives. Studies have shown that there is negative impact and is related to suicide, cancer, obesity, and the list just go on and on. The original ACEs study was conducted by Kaiser Permanente between 1995 and 1997. So there are 2 waves of data collection. It's still an ongoing study. By ongoing, I mean, they still collect medical record, drug use for those original participants. But the problem is that data is not public. Another public accessible ACEs dataset is from the Behavioral Risk Factor Surveillance System, the BRFSS. They started to collect ACEs starting in 2009 for that, but the problem is not all states participated in that study, and not all states participated in every wave of that study. But there are 3 main measures of ACEs. We have abuse, neglect, and household challenges. Next slide, please. Under abuse, we have 3 subscales. We have emotional abuse, physical abuse, and sexual abuse. I won't go into the details, but this gives you a general idea about what they're measuring. Remember, all of these questions are asking the respondents to reflect on their memories for their first memory and to the year of 18 years of age. Next slide, please. Neglect, we have 2 subscales. We have emotional and physical. For this neglect scale, it is actually added in the 2nd wave of the Kaiser study, and it's also added to the BRFSS module in year 2019. So it's not originally there. It's added later, but it has been there ever since. Next slide, please. Then we have household challenges, which has 5 subscales. We have intimate partner violence, household substance abuse, household mental illness, parental separation or divorce, incarcerated household members. So you can see, basically ask whether you have experienced any of that. Next slide, please. Now let's talk about Family Map. So the Family Map Inventory is a semi-structured interview to assess the important aspect of family and home environment. It has 3 different versions aiming at parent, 0 to 3 age group, and 3 to 5 age group. It's designed in collaboration with Head Start, early Head Start providers and families in those programs. The goal is to identify areas of concern and also strengths, so the providers can develop interventions to either reduce the risk and enhance the strength. To learn more about this study, you can visit thefamilymap.org. Next slide, please. Based on the earlier slides we just talked about, you can see that ACEs measures were retrospective, that ask you to reflect on your past experiences. But for the current study, we need something that we can do screening. We want to see whether there is anything currently going on for the children. Fortunately, my colleagues leading by Dr. McKelvey developed a Family Map ACEs measure based on proxy items in the Family Map study that mirrors the original subscales of the ACEs measure. You can see we have listed the item ACEs measure items in the Family Map on the right, and its corresponding sub-construct on the left. Studies have shown good validity and reliability of this measure, and a study using this measure has shown that ACEs score is kind of related to parent-reported health, which kind of is another reason that leads to our current study in examining ACEs score and healthcare utilization and healthcare outcomes. Next slide, please. Let's talk about the data. So the consented Family Map data is linked with ABI APCD using hash ID and gender combination. Using this combination, it allows us to uniquely identify over 95% of the population. From APCD, we pulled their insurance enrollment, medical claim, pharmacy claim data between 2013 and 2021. We applied inclusion/exclusion criteria where we need continuous enrollment for 1 year from the data of Family Map interview. Next slide, please. Let's talk about the final sample. We included children between the age of 3 to 4 at the time of interview. These are the most prevalent group that we have. Those are kids served in early childhood education setting. We have a total of 2,030 in the final sample. Gender-wise, we have about 53.2% female. For race, we have 42.2% white, 47.9% black, and about 10% from other race and ethnicity groups. But remember, for race, we do have a lot of missing, 20 to 30% of missing data on that. Regarding caregiver education level, 40% of them reported high school education, and a combined of 41% reported certificate, some college or college degree. Next slide, please. For analysis, the health utilization outcomes were categorized based on revenue codes, procedure codes, and diagnostic code and facility type. So the final product is a count variable, so it's a count outcome. A negative binomial regression was fit for that. And for health outcome, excuse me. For health outcome, we use the CCS ICD-10 to code those. And for those before October 15, using the ICD-9, we converted those into ICD-10. And it's a binary outcome, it's yes or no. But this regression was fitted. For all of the models, we adjusted for age and gender. Excuse me, I'm still recovering from sick during the weekend. Next slide, please. Here's the results. For the AIRR, that means adjusted incidence rate ratio. And you can see that only 2 of them are significant. The total outpatient visit and total health utilization. I'll use the outpatient visit as an example. So that means increase ACEs score by 1 unit. His total patient visit would be expected to increase with a rate of 1.1983%. So with age and gender holding constant, and similar thing for total health utilization. I'm really sorry. All right. We can also see that for emergency visit, they are borderline significant, 0.059, 0.053. Next slide, please. Here's the result for the health outcomes. We have 3 significant results. The tonsillitis is below 1. So that means if there's 1 unit increase in Family Map ACHI measure, there's actually a 30% decrease in the odds of getting the tonsillitis. And there are 2 over 1. One is adjustment disorders. So that means with 1 unit increase in ACHI scale, ACHI score, there's a 46% increase in odds of getting adjustment disorders. And there's a 36% increase in the odds of ADHD. And you can see that ADHD is very significant, less than 0.0001. Next slide, please. So here are some next steps. The first thing we would like to do is to using the latent class analysis to identify groups that has co-occurring Family Map ACHI scales. So basically, we want to see whether certain co-occurring of ACHIs as association with either certain kind of healthcare utilizations or health outcomes. So that will be the next step. Next slide, please. Any questions?
Yes, thank you. Kathy, were there any questions in the chat?
We do not have any questions on the chat yet.
Well, thank you so much. If you have questions later on, you can enter them in the chat later and we can note them, or send an email address directly or to our APCD service desk. Thank you so much. And I hate when I have a cough. I feel for you. No, all is well.
Okay, we got one.
Oh, yes, go ahead.
Why was age adjustment at interview made?
That is a good question. Actually, we adjusted that just because between the age of 3 and 4, there's this immunization visit, because we did look at immunization, but for like wellness check, I think there's one at either age 3 or 4, they have like a routine immunization visit. So just to adjust for that, we decided to adjust age at interview. I hope that answered your question.
Yeah, this is Mike, and that is a really good question. I appreciate it. I didn't actually enter that into the chat. I think someone else on my team might have registered under my name, but that is a good question. I was going to ask one follow-up question, Dr. Zhang, which is, it's interesting, but not surprising on the increased likelihood of the adjustment disorders. Did you look at any other behavioral health CCS categories?
I think we look at several different things, but those ones are either not significant or not interesting. So we didn't include that in the final presentation. One thing we really wanted to do is to, because I don't know whether there's a question about that, asking about like why we didn't include race as a control as well, or covariates there, because of the 20 to 30% missing values. So we wanted to add that, but it's kind of ruled out a lot of the results. I hope there are something we can do either from the Family Map side or from birth certificate data, but we're trying to include race into the control and explore more, psychosocial or psychological outcomes. But that's a good question, and we did look at several different things, but they're not significant. Thank you, Mike.
We have one more question in the chat. Why do you think that some associations were statistically significant while others were not?
Well, that's a good question. Thank you, Mario. I think it's just reflect the data we have. And again, this is between the age of 3 and 4. So at that age, it just shows some of them are more prevalent probably than other. It's actually give us good insights so we can use them as maybe a screening thing. So even though sometimes if we cannot see there's like ACEs happening, by using that, we can provide some ACEs screening like based on the association. Regarding significant or not, it's just how the data shows. If there's not a lot of prevalence, it's not showing association. It's not showing any causal effect or anything. It just shows if there is an association between ACEs and all those outcomes. Hope I have answered your question. Yes, definitely. The more control we add, the more robust, I guess, for the results. So we kind of rule out all of those different variables. Other things we don't have all of those information in that data set. So we did our best. Currently, we only have the usable is the age at the time of interview and gender. We're trying to add the race if we can get more data. But yeah, all those information are good, like royalty. If we have those information, we definitely want to add those. Yes, thank you, Kelsey.
Okay, Kenley, that looks like that was it.
All right.
All right.
I want to finish up with thank you for my wonderful colleagues, Dr. Kana Lewis, Dr. Lorraine McKelvey, and Dr. Leanne Whiteside-Manziel. They're really wonderful. I'm just on behalf of them presenting this. And thanks again, ACHI, for this opportunity.
You are welcome. Thank you for presenting to us. What an interesting subject. I'm going to move to our next topic, Arkansas opioid and naloxone prescribing trends with our ACHI's Director of Analytics, Mike Motley. Mike, and I'll just tell me when to advance the slide and I will.
Will do. Good afternoon, everyone. And again, thank you, Dr. Zhang, for that presentation. It was very interesting. I just want to talk to you all today about one of our projects that we have been doing for a few years now and updating the metrics when we receive new data. This is on opioid and naloxone prescribing trend analyses. Multiple people on our analytics team have worked on this. Edward Tewia, who's a senior analyst on our team, has really been kind of the lead on this project. So I got to give him credit, but I'm going to talk through some of what we've worked on to track these metrics. So I know you're all aware of the opioid epidemic, and there's been policies to expand access to the naloxone, which is an overdose reversal drug. Arkansas Act 651 of 2021 actually requires a co-prescription of naloxone in some situations for some patients. When they have a dosage for an opioid that is 50 or more morphine milligram equivalents or MME per day, that's one scenario. If they also have been prescribed a benzodiazepine or will be prescribed one at the same time as an opioid, that can increase the likelihood of an overdose or the risk of an overdose. Or if an individual has a history of opioid use disorder or drug overdose, this is when a naloxone co-prescription would be indicated. as far back as 2017, pharmacists were actually able to order, dispense, and administer naloxone to individuals without a prescription under our state standing naloxone protocol. So that was really meant to expand access to this drug. There are other efforts going on now to make naloxone available in some hospital settings and other things. So there's really been a lot of effort in this space to make it available. On the next slide, just a little bit more background on what we've tried to do. We're trying to have an annual metric where we track the individuals that have been prescribed opioids and the subset that have also received the naloxone when necessary. We've tried to do this at a population level using all of the data we can get our hands on in the Health Transparency Initiative, or the APCD. That includes administrative claims data and some other sources as well. We designated or categorized opioid doses of 50, greater than 50, or 90 or greater MME per day. We did that using the National Drug Codes, or NDCs, consistent with the CDC guidelines. And there's a link at the bottom of this slide that'll be made available. If you're not aware, CDC does publish a conversion file that allows you to standardize different products, different strengths, unit of measurement for strengths for individuals that have different types of opioid prescriptions, to designate them as having 50 or more MME per day or 90 or more MME per day, which is, both of those are considered high dose. They're just different tiers of high dose prescriptions. Our full analyses can be accessed at that link. Just to do a plug there back to our site. And on the next slide, I'll get into a little more of the details of what our findings have been. We have worked with the former state drug director.
Hang on, I hit the link and not the slide. Okay, so I hit this link. There you go.
Right. I knew I was dropping a bunch of links in there. Maybe.
That was crazy.
So this is the trend of the Arkansans, unique individuals that we had data for in the Arkansas APCD with opioid prescriptions. This is listing it by amount and by the annual percent change in those total counts. So we know that the number of individuals in the APCD is not exactly the same every year, but if we assume it's generally in the ballpark, then clearly there's been a reduction in individuals with opioid prescriptions of any strength, which is that far left set of bars, going from almost 386,000 individuals in 2017 to less than 239,000, 240,000 in 2021. So clear reduction there in the overall individuals with any opioid dose prescribed, a filled prescription. And I'm only talking about filled prescriptions here. The next column is those with 50 or more MME strength opioid prescriptions per day. And that too has reduced from almost 120,000 in 2017, the first study year in our study, to just over 43,000 in fiscal year 2021. And then those with 90 or greater MME has gone from 43,000 to just under 17,600 from 2017 to 2021. And we did fiscal years here just because at the time we initially ran this, I believe in 2019, the claims data that we had at that time was ending on a fiscal year. So we just did it that way and looked back 12 months like that. On the next slide, this is the naloxone prescribing trend. So this is the overdose reversal drug. You've got individuals with the blue bar and then naloxone prescriptions. We were up to 4,848 individuals fiscal year 2021 that have received just over 5,500 prescriptions. So some individuals are receiving more than one. On the next slide. So this is a look at who is, or of all prescribed naloxone doses, what proportion are being done by pharmacists. So 31.1% was the was the proportion fiscal year 2021. So that equates to just over 1,700 out of about 5,500 naloxone prescriptions under that state protocol. And pharmacists will either show up on the claim, or the name of the acting Secretary of Health will be listed under prescribing provider in the data. And so that's how we designated the ones that were authorized by pharmacists. So it may be Dr. Jose Romero may be listed, or Dr. Nate Smith. So if you're ever looking for ones that have been initiated by a pharmacist, we know that the acting Secretary of Health is told to be put in place for some of these. And that's in the link below. It's a lot of details I'm not going to go into, but if you're interested, it's in the link there, what the guidance is on that. On the next slide, this is getting into the percent of individuals who received greater than 90 MME per day opioids and naloxone prescriptions. So we'd want this to be 100%. Not there yet. We're making good progress, up to almost 11% fiscal year 2021. So that equates to 1 naloxone prescription dispensed for every 9 individuals with a 90 or more MME per day. That's up from 1 for 14 the previous previous study year. I think I've got one more slide potentially.
I think this is it.
Okay, that's it. So I think in general, just to conclude, we have operationalized some kind of standard metrics. We're looking at some other things to support some newer policy initiatives about access to naloxone. We're looking at the proportion of individuals that have opioid and benzodiazepine co-prescriptions or concurrent prescriptions. And there's a separate method there to kind of define that. And again, Edward is kind of leading on that. And so hopefully that can help providers that are seeking to provide access to naloxone kind of understand how many patients either in their area or that they've historically served in one capacity or another that could be a recipient of naloxone. So we will continue to update these metrics, and I'm happy to pause there and take any questions from anyone.
Okay, we have one question from Mahip. Does the naloxone prescription also include naloxone combination products such as buprenorphine naloxone, aka Suboxone?
I'm trying to remember. I think we were pretty inclusive, but I may defer. I'll either have to come back to you or defer to either Edward or Nicole on the call if they know offhand. If not, I'll follow up with you all.
Okay.
Anybody have any other questions? No. Okay. Mike, thank you so much. That was very interesting. The information about the prescriber name and the Secretary of Health was very interesting, a nuance that wouldn't necessarily be obvious.
Thank you.
We always learn something. All right, so at the beginning of this session, I warned that we might skip this section if time did not allow, but I believe time does allow. So let's look at a couple of questions from other APCDs. We began including this section a few webinars ago, got positive feedback. We can always learn from other states and data users. So I found 2 questions, one from Massachusetts and the other from Maine, that I thought I would include. For those who aren't that familiar, right now, 18 states have APCDs, 8 are implementing them, an additional 8 have strong interest. States with APCDs can be very, very different. Arkansas is different than Florida. Florida is different than Massachusetts, etc. But there's the data use questions have a lot of common threads. And so hopefully we can get some value out of what we're going to see today. All right. The first question comes from Massachusetts. This is long. I left all this content in here for when you review these slides after, but I will summarize what this is. The data user's question is, last year, CMS announced new ICD-10 CM diagnosis codes would be implemented to distinguish vaccination status. Are the codes currently submitted by hospitals for patients in case mix data or by carriers for members in the Massachusetts claim? And per CMS, 3 new codes were created. So they were created in April of 2022. So yes, they do exist. The links here provide more context and information. And the CDC advises that when applicable, these codes can be used in combination with code Z71.85, which is encounter for immunization safety counseling. Yes, but here's the fun one. All of these codes are found in the Arkansas All-Payer Claims Database in the medical claim diagnosis code fields, MC041 through MC053. The data dictionaries are online if you want to get the data element names, but those are the primary diagnosis code fields. We have 12 of them. The 3 new codes can be found distributed across all 12 of the fields, not just the primary one. So if you are looking for immunization codes, these codes look in all the fields, that not just primary, and then you'll get your cohort of it. So that's the Massachusetts question. The main question is there a way to calculate how many procedures were in an encounter? And I'm not going to read all of this, but you can do this. We have done this in the Arkansas APCD. There's some helpful hints in this blue box below. You could identify outpatient claims by using bill type. And there's some specifics here. And then the HCPCS codes equate to Arkansas APCD procedure codes, which are an MC055, and then dates of service. And then that, depending on your study question, using those fields, you can create an encounter using APCD data and figure out how many procedures were in that encounter. Again, this is a teaser. If you'll have this slide after, if you want to study it in more detail, and if you need more discussion, we're happy to help you. Just reach out to us and we'll schedule some time. All right, that didn't take long. Now, let's talk about the latest APCD release information. The last time we had a webinar was in July, and since then we have released more data. We now have data from January 1st, 2013 through March 31st, 2022. The release notes, and I'm going to flip over those momentarily, have a very good summary of all the things that have changed in this particular release. We have new fields, we have revised fields, there were new submission requirements from the carriers. And so let me try, I'm going to stop sharing real fast and then go over to my other screen, stand by. So hang on, my apologies. When I accidentally hit the link in Mike's presentation, I got rid of my screen, but I can get it back. Okay. All right. I'm getting there very soon, and it's right. Okay, sure. All right, if you click the link that's in the deck, it will take you to the APCD release notes for this build. And the data, the data ranges for the different categories of data. We have some submitting entity specific information here. We've resolved a lot of issues that have been lingering. There's still some open issues, but this will give you a summary, data tips reference when possible. And then at the bottom, we talk about the new fields and the revised fields in detail. I'm not going to go over this document. I'm going to let you go over it at your leisure and reach out to us and ask questions. But what I will do is provide a summary. Stand by. So I'm unfamiliar. I don't remember if you're familiar with the term DSG or the data submission guide. And the data submission guide is the are the submission instructions we give to the carriers who have to give data to the Arkansas all-payer claims database. And periodically we revise the data submission guide to add new fields or revise existing fields. So what you see here, well, let me back up one more step. The last time we had a change to the data submission guide was in 2017, and we collected several different things over the years, and we asked for a change in December 2021, and we're just now beginning to get these new fields and these revisions. So here's a summary. The screen you see here are the new fields that we are collecting data for. We are requesting from the carriers, where possible, Hispanic indicators. There's another slide on the Medicaid aid category, so we'll get to that in just a minute. Point of origin code, other insurance amount paid under medical claims, dental claims, payment arrangement type, diagnosis code, ICD indicator. We didn't have that in the dental claims before. Up in pharmacy, payment arrangement type, postage amount claim. So these are new fields. And it's important to note that we didn't ask for retrospective data. So if you're looking for values in these fields prior to June of 2022, when these carriers were supposed to start submitting, you won't find anything. And it's going to be hard. Some of these fields aren't going to be well populated anyway. It's very hard for a carrier to find member Hispanic indicator. And if they don't have it, they have to get permission not to submit it. But where these data are available, they do come in, they are popular. All right, the next, there we go. Some revised fields. So we had already had data placeholders for race and ethnicity and language for the members and the subscribers. And so they were optional to begin with. So if the carrier had them, they sent it. If not, they didn't have to, it didn't matter. And because they were optional, the values that were sent were not, they had no consistency. For example, some carriers, if they did have language, they could have used their own abbreviation because the data was not required at the time. Same with race. And now these fields are required, and the values have requirements for consistency so that they will be easier to use going forward. Again, we didn't ask for retrospective data correction if a carrier supplied their own values, and we're working on some transformation to help levelize that. A reminder, I'm going to say it again, because this data was required. We were supposed to be receiving these data from June of this year forward, and it won't be in years prior. And it may not be well populated. So, okay, next slide. A couple of fields had a definition change. For example, these particular fields are related to, previously they were limited just for inpatient stays, but we have expanded the definition to include institutional stays as well. It should have had the two all along, but it didn't. It had just inpatient. But now they will have inpatient and institutional. There are more detailed notes in the release notes. Like the others, these data will be available. The change in this definition is available from June 2022 forward. So if you have more questions about this, again, check the release notes or reach out to us to help, and we'll do what we can. Okay. So let's talk about on those new fields for for member medical claims, pharmacy claims, nail claims, there was a field called Medicaid aid category. Well, we have changed that so that for Arkansas Medicaid claims and our Arkansas pass claims, PASSE, the pass data, the state aid category field, which points to the type of coverage or plan the Medicaid member is utilizing, is now going to be in ME 910, or the fields that end in 910, ME, MC, PC, DC. And this field for Medicaid data is going to be the federal aid category, not the state aid category. The state one will be in 910. And in the previous data, the claim level state aid category was not available. It was only at the member level. So those are new fields. MC 910, for example, will capture the Medicaid state aid category at the claim level, not just the member, and so forth with pharmacy and dental. So that means that from data previous to June 2022, the only Medicaid, well, that's not entirely true. In the release notes, there's generally prior to June 2022, the Medicaid state aid categories won't be populated at the claim level. They'll be at the member level. But thereafter, it will be as this field, as this screen describes. A little complicated, wouldn't blame you at all if you reached out to us and we'll go through it. Happy to do it. But this was our way to capture very important data, add important data at the member level, and also provide additional granular data at the claim level about the Medicaid state aid categories. Okay. That's a lot. And with every release, we update all of these documents. The release notes, of course, there are universe counts, which provide counts, all sorts of counts about the data, frequency counts, claim counts by month, and the data dictionaries are updated as well. So feel free to look at all of these and reach out with questions. And we are very open to producing different counts. If there is a type of count you want to see about the data, then we can definitely produce that for you. Also, the hardest part about using our data is how to link it. Because when you access this data, you will almost always have multiple tables. You'll have members in one table and medical claims in another table and pharmacy claims in another and dental in another. The data attributes deck, which is found on the website, will help you understand how to link the data and build your analytic data set. Again, reach out to us. So there are new data tips. In the interest of time, we're going to move beyond that, but do always please check your data tips. See, don't forget, I'm telling you that twice. And we caught up and did really, really well on the time today. Oh, here's our technical support. I believe Kathy put it in the chat as well. At this point, Kathy, are there any questions in the chat?
I don't.
Nope.
Nope, just me.
Thank you. Okay. Our next data users group is January 25th, 2023. And for all of you data users out there, please send us any ideas. If you want to present your work, happy to have it. Also, we're pondering the development of new data assets for sale to data users or for access to data users. And you can expect us to reach out to you, whether it's a survey or just individually, to ask what you might like to see or have in the APCD that would make it easier to use. Because it is a big, complicated beast when you get all of the data. So look for that, and we welcome all of your input. So unless there are any other questions, I am going to give you back 8 minutes. Yes? Thank you so much, everybody. I look forward to your questions. Contact us offline and let's get together in January.
Thank you.